This is part 2 of high altitude illness presentation. The objectives of this talk are to present two cases of more dangerous conditions that can occur at high altitude. Those are high altitude pulmonary edema and high altitude cerebral edema. We will also summarize what you have learned in these two sessions on altitude illness. So let's move on to case 2 of our presentation. This was also seen at Manang Clinic at 3,500 meters. Our patient is a 45-year-old Nepali man who presented with dyspnea, or shortness of breath, and cough for the last 1 day. He arrived from Terai region, a low-lying region of Nepal 3 days prior. He's here collecting Yarsagumba. This is a short aside from our high-altitude illness presentation. Yarsagumba is an aphrodisiac. It is also known as Himalayan Viagra, and it is more expensive than gold in certain parts of the world, including China. It is a fungus that infects moth larvae in the summer, mummifies it, and then grows out of its head in the spring. Check out the photo above. And it is found above 3,500 meters in the Himalayas. Below you can see a photo of a camp of Yarsagumba collectors, many of whom arrived from low regions of Nepal. Let's go back to our case. Our patient took 2 days to come up from Terai, low-lying region of Nepal. And the reason why he was able to do this is because there's a road being built on Annapurna circuit. He's never had any prior altitude issues. On exam, you find that he has RALS. His oxygen level is low. It's 78% on room air. He has a low-grade temperature of 38 degrees. His respiratory rate is slightly increased, and his pulse is 110. In this case, what do you advise to your patient? A. Take nifedipine and see how you feel tomorrow. B. Take sildenafil or Viagra and descend by 1,000 meters today. Take some Lasix or furosemide, a diuretic. And D. Be treated for pneumonia with antibiotics. Our patient is suffering from HAPE, or high-altitude pulmonary edema. The symptoms of HAPE are dyspnea, fatigue, and this fatigue is a bit unusual. The person might have been leading the group the day prior, and today they're falling far behind. Cough is also part of HAPE. Initially, it could be dry, and then it develops into more productive, frothy sputum, and usually occurs after 2 days at a certain altitude. Signs of HAPE are hypoxia and RALS on exam. And the risk factors for HAPE are lung disease like COPD or pulmonary hypertension, any kind of respiratory illness, maybe a viral URI, a fast ascent, exertion, high final altitude, and also genetics. Differential diagnosis to consider are pneumonia, PE, CHF, MI, myocardial infarction, pneumothorax. Of course, if you're at high altitude and the timing fits, HAPE will be your leading diagnosis for a patient in respiratory distress and severe fatigue. Pathophysiology of HAPE is quite complex, and we are not going to cover everything on this flowchart. But the important thing to remember is uneven hypoxic pulmonary vasoconstriction occurs. This results in overperfusion of certain areas of the lung. This in turn leads to capillary stress failure and capillary leakage of proteins. Eventually, this process becomes inflammatory in nature. HAPE is distinct from pulmonary edema seen with CHF, or congestive heart failure, which is usually fluid overload problem. HAPE is more of an elevated pulmonary arterial pressure and leaky pulmonary endothelial problem and is treated differently. Diuresis does not help patients with HAPE, and their echo is usually normal. Here is a chest x-ray of a patient with HAPE. As you can see, there is bilateral pulmonary edema. And this is a chest x-ray after the patient descends. There's a rapid clearing of fluid from the lungs with descent. How does one prevent HAPE? Slow ascent is key. Follow the recommended ascent profile, as rapid ascent predisposes one to HAPE, a devastating disease at high altitude. Salmeterol has been studied and is useful in HAPE prevention. It is a beta-2 agonist. Nifedipine, a calcium channel blocker, is used to lower pulmonary pressure. Sildenafil, which is Viagra, and tadalafil are both phosphodiesterase type 5 inhibitors and also act to lower pulmonary pressures. Dexamethasone aids in HAPE prevention as well. How does one treat HAPE? The two key steps in treating a patient with HAPE is descent and oxygen administration. A descent by even 1,000 meters can save a patient's life. If those two options are not available, hyperbaric bag can be used. It's a temporizing measure that can simulate descent by 2,000 meters, and it can turn a patient around who is waiting for evacuation. Nifedipine, sildenafil, tadalafil all lower pulmonary pressures, and one of these should be used on a HAPE patient if it's available. Non-invasive ventilation also has been studied and is efficacious in taking care of HAPE patients. But remember, descent and oxygen administration are the most important steps. Furosemide, on the other hand, has no role in taking care of a patient with HAPE. These patients are not fluid overloaded like your heart patients. So going back to our case, you recommend the patient to take sildenafil or Viagra and descend by 1,000 meters today. So what happened to our patient? He was administered sildenafil 50 milligrams. He descended on motorbike to 2,500 meters, and we educated him on dangers of altitude illness, specifically on not ascending too fast to an altitude. This is a photo of my colleague at the Menang Clinic giving a lecture to trekkers who are passing Menang while doing an Annapurna trek. This is a daily lecture given in the afternoon and teaches trekkers about dangers of altitude illness and how to recognize it and treat it. So let's move on to case 3 that was also seen at Menang Clinic at 3,500 meters. Our patient this time is a 62-year-old male from South Korea, and he's carried down to us by a Sherpa with altered mental status. He's completely disoriented. He's moaning when you come up to examine him. You hear rowels on exam. His oxygen level is only 46% on room air, and he has non-focal neurological exam. By the way, this is a photo of me just prior to seeing this patient hanging out in the hammock outside of the clinic. So what is the background for our case? Our patient is in general a healthy male. However, he developed upper respiratory symptoms 3 days prior to seeing us in the clinic. He then developed extreme fatigue at 3,900 meters. This required him to hire a donkey to proceed further up to 4,200 meters. Overnight, he developed a lethargy and was unable to walk. At this point, his guide hired a porter who carried him down to our clinic. Note, it's almost never a good idea to hire a donkey to keep going up in altitude. If you are not feeling well at high altitude, you should let your body acclimatize at the same altitude and never proceed any further up. So what are your immediate actions to save our patient? All of these are correct except for one. Place the patient on 15 liters oxygen via non-rebreather mask. Administer dexamethasone. Administer furosemide or the diuretic. Check his blood glucose to make sure he is not hypo or hyperglycemic. Our patient is suffering from high altitude cerebral edema and probably also from high altitude pulmonary edema. So HACE is a progression of acute mountain sickness. The key symptoms that distinguish it from AMS are ataxia, or unsteady gait, and confusion. Otherwise, you can think the patient is acting drunk. About 13 to 20% of HACE patients also have associated HAPE. Some risk factors for high altitude cerebral edema are rapid ascent, as is a risk factor for everything altitude related, prior incidence of HACE, and genetics. Differential diagnosis includes alcohol intoxication, which can occur, but this should be your diagnosis of exclusion. CVA, cerebrovascular accident, intracranial hemorrhage, a brain mass, electrolyte abnormality like hyponatremia, and hypo or hyperglycemia. So you should consider all of these when you're taking care of an altered patient at high altitude. But once again, because you are at high altitude, HACE should be your leading diagnosis. So HACE pathophysiology, really it's the same mechanism as severe AMS. You develop vasogenic cerebral edema, and eventually you'll develop cytotoxic edema of gray matter, herniation, and death. How does one prevent HACE? You take the same steps as for prevention of acute mountain sickness. Do not ascend too fast. Follow the recommended ascent profile. Take Diamox as needed. And dexamethasone is recommended if you have history of prior HACE. Treatment of HACE. The two important steps in treatment of any dangerously sick patient at high altitude are descent and oxygen administration. So these are the first two steps you will do for a patient who you think might have HACE. Hyperbaric bag shown on the left can also be used as a temporizing measure for the patient who is awaiting evacuation. The way it works is the patient is placed inside the bag and is zipped up, hopefully with oxygen attached to them. There is a small window that you can communicate with the patient. Then you use the pedal to pump air into the bag with your foot. The pump also lets carbon dioxide exhaled by the patient to be removed from the bag. Another treatment for HACE is dexamethasone, and that's 8 milligrams IM. So your immediate actions include all but what? Administering furosemide. Furosemide in general does not have a role in high altitude illness. All the other options were correct. So what happened to our patient? His finger stick was normal at 120. We placed him on oxygen at 15 liters non-rebreather mask. He was given sildenafil Viagra 50 milligrams and dexamethasone 8 milligrams IM. We also performed neurological and respiratory checks every 30 minutes on our patient. The following day, he was much improved. He was awake, eating, and talking. However, he persisted to be ataxic. He was carried down to the helipad and evacuated the following morning. In the photo, you can see the Korean team of filmographers who helped us with translation for the patient and communicating with him and actually helped us carry him out. Finally, let's summarize. Here are some altitude pearls. Remember, prevention is key, and genetics play a role. Some people take longer to acclimatize than others. Remember also that descent is almost always the answer, especially in a patient who is dangerously ill. You should never send a patient by themselves who is ill down. Know your medications if you are going to be taking care of patients with altitude illness. Be always prepared, and do not forget your differential diagnosis. Here are some references for this talk.